Hello, and welcome to Line 1, Your Health Connection. I'm your host, Dr. Jillian Woodruff. Sex therapy is a crucial but sometimes misunderstood facet of mental health. Studies suggest that up to 40% of women and 30% of men report sexual dysfunction at some point in their lives, highlighting a widespread need for informed discussions on intimacy. Sex therapy for couples and individuals can strengthen connections, enhance communication, and revive intimacy. Today, we will unravel the layers of emotional and physical intimacy with insights from our expert, Mrs. Rebecca Love. Rebecca Love is a lifelong Alaskan who works in private practice as a licensed professional counselor and AASECT certified sex therapist. She grew up in Anchorage and has a bachelor's degree in psychology with a master's degree in counseling psychology. She has worked for 17 years with individuals and couples and is currently one of only a few certified sex therapists in the state. Additionally, she facilitates the Extra Toughs support group for gynecological and breast cancer survivors throughout Alaska. Ms. Love, welcome.
Thank you. Thanks for having me and for honoring this important and vulnerable topic.
That's right. And speaking of vulnerable, we are discussing sex today. So this is a topic for adults. We will be discussing sensitive subjects. So today I brought my sexy voice to fit our topic. I lost my voice, I think, yelling at the kids last week. And I've done everything to have it come back, but this is as good as it's going to get. So I do not sound like myself. But Ms. Love, I know you have so much to share. So even though I love sexual medicine and discuss this daily in my practice, today we are just going to leave it to you and I will do less talking. So that will be new.
Yeah, absolutely. It's a good thing I'm a talker and have a lot to say and share with our audience.
We are excited to learn from you. So let's start off by just explaining, what is sex therapy?
Yeah, so sex therapy is a branch of therapy that looks a lot like every other kind that you might be more used to. It is, excuse me, it is occurs in the clinical office. I will note here that it is not a hands-on type of therapy. And so that is a common myth and misconception. We are often working with clients with curiosity and trying to approach the topic with reducing shame and research education that helps people feel more empowered in their individual relationship with their body and in their relationship with their partner.
There's different types of therapy, right, that deal with relationships. What are those other types of therapy?
Yeah, so some people go to couples therapy. They might see an LCSW or an LPC or an LMFT, a licensed marriage and family therapist. They have extra training in couples work and ideally extra training in sexual topics as they come up so often with couples. Psychologists also do this kind of therapy, but we can talk a little bit about what it means to be a certified sex therapist.
Yes, please tell us.
Yeah, so there's a few certifying bodies in the nation. I am certified by AASECT, which is the American Association of Sex Educators, Counselors, and Therapists. There's only a few of us here in the state doing the good work that we do, and our work is actually quite in high demand here. So there's a lot of extra training and expertise that goes into dealing with this topic.
Do you do other types of therapy in your practice?
Yeah, so part of being a sex therapist, in order to even be certified, you have to have a master's degree in mental health. You have to be licensed in the state that you practice in. And in Alaska, that requires 3,000 hours of postgraduate clinical training and supervision. To be an AASECT certified sex therapist, you also have an extra 150 hours of education in certain and special topics to address diverse crowd of folks who might be coming for services. We also do something called a sexual attitude readjustment training. It's required as part of certification so that we can address our own biases and topics that may make us uncomfortable from our backgrounds and work to neutralize that so we can meet clients where they are. It also requires supervision by an AASECT certified supervisor as well.
This seems very specialized. How did you become interested in sex therapy specifically?
Yeah, I mean, I took in all psychology classes in college, whenever we would talk about this topic, I thought, my goodness, how interesting, how many things we can learn about this, and what an important topic that everyone has a relationship with in some way, but most people struggle to talk about, even with their, closest family or partners or providers. Dr. Ellen Cole taught at APU and was in charge of the master's program there for years. And she was Alaska's first AASECT certified sex therapist. So I worked with her and taught a class with her as well at APU.
So your practice, do you think it is the majority of the patients are there for sex therapy?
It's a mix. I actually see a lot of clients just as a general licensed professional counselor. I work with trauma, anxiety, depression, relational issues, job stress, body image, all kinds of stuff. And sometimes really directed in sex therapy issues. One of the models we work with in sex therapy is Dr. Jack Annan's model called PLICIT. And that acronym stands for, this idea that most people need permission in order to work on their sex lives or work with their partners in a way that addresses some of the issues they might be having. If that, after permission, we look at limited information and offering specific suggestions. So that's the PLIS in PLICIT. And if that's not enough, if reading a book, if listening to this talk isn't enough, then you may be someone who's a candidate for intensive therapy, which is the IT in PLICIT and kind of the last stage of things.
What is the climate of sex therapy here in Alaska?
Yeah, I'm glad you're asking that. I was a little worried to come on the radio because I have such a long wait list already. A lot of folks are in Alaska reaching out for this service. There's just a few of us doing this work that are certified. And so it's kind of tough. It might require being on a wait list. I encourage people to reach out for support when they first decide they might need that help, because it may be a little bit before you can get in. Luckily, telehealth has helped with access. Throughout Alaska. I have clients all over the state, not just here in Anchorage. So that's been helpful. But it's a resource that's in high demand.
Do you have to be licensed here in Alaska in order to perform this?
Yes.
Oh.
Especially if you are a person, who is certified. If, a lot of people can say they do sex therapy, but I would encourage you to really look into the credentials of the person saying that and make sure they have quality training in order to do so.
Is there a role for sex educators or sex counselors or sex coaches? Is there a role for that in places where they don't have therapists? Absolutely.
And, actually, if you go to AASECT.org, you can search for professionals in your region. I'm actually not familiar with any counselors or educators here in the state as of yet, but lots of people are working towards training. One of my favorite authors, Emily Nagoski, whose work I'll probably reference today, she's a sex educator and brings a lot to the conversation.
Is this type of therapy covered by insurance?
Yeah, that's a complicated question, and it really kind of depends on your insurance provider. Some have very specific guidelines on what is covered in therapy, what is not. It's always changing. I think it's great to check in with your insurance provider. But a lot of folks who are seeing a therapist for any kind of other issue, it's sex therapy isn't necessarily cordoned off. So perhaps a person who's presenting with a lot of anxiety, we can work on how that manifests in their relationship or in their sex life under, that general umbrella.
So this may fall under mental health.
Yeah. Absolutely.
And so if you have mental health services, you may be covered for this. Okay. Well, out of curiosity, are most of the clients that seek you out or are referred to you, are they mostly females or males or couples?
Yeah, so I seem to have a bit of a kind of niche practice in Alaska. I think partially from starting out in an OBGYN clinic at Providence. I started work there, and so I've often had a lot of referrals from providers, from OBGYNs, from nurse practitioners. I see a lot of women. I see a lot of heterosexual couples. I see some individual males. But I would say that range varies depending on which of us you're talking to. But for me, my expertise and most of my clinical experience is with women and couples.
Why do you think that you see mostly women? Is it just because you started off in the OBGYN practice, or is there something else?
Yeah, I think partially. I think it's also like referral from clients who have seen me, will refer their friends or family members. I also think, I work a lot with things like sexual pain, with trauma. And on that note, by the way, if any of our topics today bring up, our listeners' own personal trauma, I would encourage them to reach out for resources. I realize this is a vulnerable issue. And I think that's why, a lot of women who are experiencing pain or have experienced trauma in some way might feel more comfortable seeing me versus some of the other providers.
Yes.
Even though they're fantastic.
Yes. So they just made me more comfortable because speaking to another woman about it.
Yeah.
Okay. Well, what are the most common issues that women present with? And then what are the most common issues that men present with?
Yeah. So when we are doing sex therapy, we're often the general umbrella. We're looking at issues or concerns that are coming up around 4 main topics. And those include pain, desire, orgasm, and arousal. And so for women, this often presents in terms of a issue with desire discrepancy, or a discrepancy between their feelings of drive and desire and their partners. We look at difficulty with arousal. We look at, post-cancer treatment, pain, pelvic floor dysfunction. Those are the main topics I find that women come in with. Men, when they come to me, tends to be more around issues with climax and timing of that, whether it's, in general, performance anxiety or a delayed or a rapid timing that feels like it's not working for the couple.
Is there a specific age range where you see mostly people in this specific age?
Yeah, boy, it's so interesting because I think when we're working with any human, we're working with all their parts of self. And so sometimes young parts of them show up to this work, right? Education they received as a child that has been problematic or, so yes, I think with any person, we're working with their entire development. But also, my clients have ranged from, I used to see, teens up to, I don't know, mid-80s, I think, are the people who've been reaching out. Mm-hmm.
Wow.
Yeah.
Do you think there's sufficient knowledge about what you do amongst other medical providers? You did mention you're in an OBGYN office, and I know we do not get a lot of sex education really at all in medical school or residency.
Right.
So it's something you have to seek out. So I think that practice was pretty progressive to
Absolutely.
have you. Yes.
Yeah. A local practice here, Anchorage Women's Clinic, took a risk on me and helped launch my career. And really, I think we provided a ton of support in-house to people who may not have sought out sex therapy, but were coming for, their medical visits, their postpartum visits, and we could capture a lot of people in that model. I have been invited to instruct and teach at the PA program here at UAA, at the nursing school. The WAMI students, when they came through, would come and listen to a talk of mine. I am lucky to receive a lot of referrals from medical providers here, but I imagine that there's a lot more who could benefit from knowing there's some of us out here doing this work.
Yes. Well, offhand, is there a specific type of patient or a specific complaint or issue that you think would benefit most from sex therapy, and maybe something that you don't see as much as you think you should?
Yeah. I think that I'll just go really broad with that and say, you know, you and I have talked about this a lot, of people who are wondering whether they are quote unquote normal, people who are wondering whether they are broken. And I would say a huge thing we try and fight in sex therapy is a culture or a legacy of shame. It's really tough to share your body with someone when you don't feel good about that body. And so that's a lot of the work that we do.
Yes, that's true. I mean, there's a lot of, it's a very vulnerable time to expose yourself to someone. And very true as you go through life, and there may be changes. I mean, there's changes early on, let's say after pregnancy, your body changes, it's new to you. And then to expose that to someone else, it's difficult, even if it's a partner that you may love.
Right.
You know?
Yeah, there will be changes.
Yes.
There will.
Absolutely. Physical, mental, all the things. Well, can you address some of the common misconceptions about sex therapy?
Yeah, I'm really glad to be asked that. One of the reasons I'm on here today, I think people have a picture of sex therapy that may have come from some popular movies. There's actually, here's my plug for a movie that actually does a fantastic job of showing what sex therapists work looks like. It's called Hope Springs. It's actually Steve Carell who's the sex therapist, but I actually use that video sometimes when I get invited to speak, just to show the kinds of questions we ask, the kind of work that we do. It's a great example. I think most people assume that it's about spicing things up and it's about addressing how to add to sex to make it more pleasurable and sustainable. And while that is true, I think a lot of the time we're working with what puts on the brakes for people. What is holding them back? What are the mental health issues, the medical issues, the internal issues that are causing them to not be able to show up in a way that feels good to them?
Can you talk about the fantasy of sex versus the reality of sex?
Oh, yeah. I'd say we live in a really confusing culture, particularly here in America. We have a really interesting relationship with sex education, but have very hyper-sexualized images in most of our media. We have very unhelpful gender norms that tend to make most people feel that they can't really fit into that. And so I would say that is definitely one of the pieces that are problematic in our culture. Aging is a huge part of this, right? Disability, gender variance or relationship variance. When we don't see that growing up, we think that's abnormal. And so what we try to do is fight this narrow version of who a sexual person is and what that person is.
Is it possible even to eliminate shame from real sex talk?
Yeah. I think that it takes a lot of work to deprogram what has been programmed. I like to use Emily Nagoski's garden metaphor. It's in her book, Come As You Are, and she talks about all of us being born with a nice fertile plot of soil as our sexual self. And we have this lovely, healthy little plot. And over time, culture and our parents and maybe our spirituality plant things in there and nourish them. And some of those things are really healthy and lovely. And some of those things are really toxic. And we in sex therapy are looking at weeding that garden and nourishing what is life affirming, what is healthy, what feels good, and taking out the weeds of what is, and a lot of those are related to shame.
How long does it take to weed that garden? That sounds like a lot of work.
That's a great question. I think some of that work, can be done in therapy. A lot of that work can be done on one's own, even knowing about that metaphor and deciding, what is your garden? What's your partner's garden? And also, what are the gardens we want for our children? My hope is that my daughters have a lot less work to do on that than previous generations.
That's right. Let's start to address some of the common narratives that you hear from patients, some of the things that I hear as well. And we're going to take a break, but I want to talk about obligation sex and a partner who feels like they may be in a monogamous a married relationship and they feel like they have to perform for their partner.
Yeah.
And it's not for pleasure or for procreation, but just for
Right.
pleasing the partner. How do you address that?
Oh boy, that's a big one. Yeah, I would say this topic comes up so frequently and often comes into therapy from a desire discrepancy space. So every couple is discrepant in desire. Not every single couple wants the exact same amount of intimacy at the exact same time. My broad answer to this is actually, I've seen some real improvement on this throughout my career. I think we're moving away from both partners. The higher desire partners are less interested in their partner just having sex that is performative or obligatory, and more interested in, what we work on is having couples try and have the sort of physical intimacy that they would like to have again. And that is unlikely to happen if we're having intimacy where we're not giving the chance for arousal to come on board, where we're not taking the time we need to shake off the world and really engage in pleasure. I would also say that in a monogamous relationship, I do think it's our work to look at how can we make ourselves, how can we bring ourselves to the table, in an authentic way? How can we do our own work around that so that we're showing up for that relationship as long as, yes, we're not experiencing pain, as long as we're dealing with our trauma, that sort of thing.
Can you talk to us about the different types of desire?
Yeah. So again, Emily Nagoski has some great resources on this and talks about the framework of spontaneous versus reflexive or responsive desire. I think when we think about desire, we're thinking about spontaneous. We're thinking about, walking down the street and are just noticing this desire to be physically intimate, a message almost from the body to the brain. And through a lot of complex research and a lot of time, we've realized that not everybody starts their sexual response cycle with desire. And in fact, a lot of women, not all, but a lot of women will report that desire is not the first thing to come online. It comes later in the cycle if the right context is present and the right type of stimulation and the right type of environment. Then desire shows up at the desire to continue being intimate with someone.
What is a reflexive desire?
Yeah, so that's more when we're responding to the desire in somebody else, or when we're, for example, for decades, women have been reading, all kinds of people have been reading literature with erotic themes in it, to sort of bring the brain to the table. A lot of who I see are women, and one of the main issues is this. It's not usually an issue with the genitals or with the body. It's usually an issue with the brain, and getting our brains in the game, removing the barriers to accessing pleasure.
The brain is our biggest sex organ.
Yes, that's right.
Yes, I always say that. Can your type of desire change in time?
Yeah. And I think, for example, for a lot of women, they'll say maybe around ovulation or with their cycle, they'll notice more of a spontaneous desire at certain times. Certainly, a lot of people will report this is very strong at the beginning of a relationship in the first 18 months. We see in long-term relationships that tend to shift to some degree, although plenty of people always have spontaneous desire. Some never have it. What I think is exciting about the work around this is we're not trying to chase that down as an essential factor in having a satisfying or sustainable sex life. Now we understand that either way you're coming to the table, you can work with that.
How do you assist couples in navigating different types of desire, this desire discrepancy?
Yeah, well, I think, I joke about having this sign in my office that says, do not assume your partner is anything like you. And that applies to a lot of things,
yes,
but that applies here as well because, first of all, it's unlikely our partner experiences it exactly like we do, and they don't have to. We need to really understand what is desire, what brings someone to the table. Sometimes their body just gets them there. Sometimes a lot of other resources or tools or factors need to be addressed in order to have the, privacy, the space, the relaxation in order to access desire. You and I talk a lot about, for parents. I mean, when you have kids in the house, like there's a lot of barriers to being able to access that. There's a lot of the daily life that has nothing to do with eroticism or is quite aversive, actually.
Right.
So.
Well, this is a question that many people have. What is a normal amount of sex to have in a monogamous relationship? Let's say a monogamous married versus unmarried relationship.
Yeah. And I feel like I would be remiss to answer that with an objective number. As a sex therapist, we look at normalizing a broad range of people's experiences. There is, I will say, for those who are highly interested in the data, the Kinsey Institute at Indiana University does regular research and posts information about frequency in all different sorts of setups of relationship. I have had couples who have, intimate encounters or sex many times a day. I've had couples who it's been, 5 years since they have. Something, without saying an objective number, I would say that I was telling you, it's hard to cold start an engine. So the longer you go without relating to each other in that way, the harder it can be to get there again. And so working with momentum is often beneficial.
You have to keep that car plugged in
That's
little
right.
bit.
That's
right. Okay. Well, I often talk to my female patients about different types of sexual intimacy because it is not all penetrative.
Right.
So can you describe some of the types of sex that people encounter?
Yeah, and when we use the word sex here today, we are, I think using that really broadly. Let's remember that penetrative sex is not available to everyone for all kinds of reasons. I work a lot with people post-cancer, a lot with people with pelvic floor dysfunction. And so, for those folks, sometimes we're talking about, it's actually called outer course, ways to, luckily the body is so diverse in its nerve ending response, and we don't have to focus on just the genitals. A lot of married couples, a lot of people who've been together for a long time, married or not, tend to start skipping all the buildup and will go straight to thinking that penetrative sex is the best thing. And,
to be efficient with their time?
Yeah, to be efficient, which is fair. And like I said, if you're trying to reproduce, maybe that's what you need to focus on. But most people are just trying to connect with someone. And it's really important to broaden that picture in all kinds of ways.
So what I'm hearing, though, is that with long-term relationships, the appetite for sex may change. It may decrease.
Yeah.
Is that something that we see?
Yeah, absolutely. And I think a part of that is the brain responds to novelty. One of the things that lights up the brain is being delighted, having an experience you may not have known you were going to have, exploring with curiosity. We can get a little less curious about our partners over the decades, right? And so, sure, I think most couples have some work to do around that. There is a book actually that just came out called Magnificent Sex by Peggy Kleinplatz and her colleagues. And that's pretty fascinating because that book interviews and looks at couples who identify as having exceptionally good sex lives over many, many decades and looks at what are the common traits in those relationships. So not everyone, but a lot of people have to really fight for and prioritize their erotic connection when there's so much in modern life that competes with that.
What advice would you give to couples with or without kids who want to prioritize their intimacy and their sexual relationship, but they just don't know where to start?
Yeah. I linked to this talk a lot of resources, TED Talks, books, thought leaders in the field on my website to give people an opportunity to do some exploration on their own. But I would say that, so much of what happens in modern life is scheduled. People often balk when I say, I think you need to schedule physical intimacy. And I want to be really clear when we say that as sex therapists, we are not saying you need to schedule penetrative sex. We're saying would be, you need to set the stage for some kind of physical connection on a regular basis. And what that often takes is shutting out all the other stuff. Maybe that's your screens. Maybe that's having someone watch the kids. Maybe that's, not checking your work email after, 9 p.m. or something. So it's really carving out the time and space for it. Esther Perel has a quote I really love about this, where she says, sex is not a thing you do, it's a place you go. And I really like that definition, because what we're asking people to do is, help the odds that you're going to go to that place and see what happens there. And ideally, it's pleasure.
Not a thing you do, but a place you go.
Yeah.
Do you find that the sexual relationship can really strengthen a relationship, but then also it can really tear down a relationship? And is that typically due to a desire discrepancy, or what aspect of sex can tear down a relationship?
Yeah, I mean, there's kind of a saying in the field that when sex is going well, it's like 5% of the relationship. When it's not going well, it's 95%. It's just this elephant in the room. And I think that's really true. We have to look at why that is and help people feel less alone. I mean, I think one of the factors that causes so much suffering and distress around that is people feel anxious to talk about it. They don't have someone to talk about it to. They're worried to talk to their partner about it. We really are not, most of us, raised with a whole lot of skills for those conversations. And so it keeps it this really tough, vulnerable, somewhat scary topic for a lot of people. And, we're working to fight that.
And we may not have had, talk to our parents about it. My family was very open, and some families are not very open. And so it's kind of, when you don't discuss it, it does become more of a taboo subject.
And when you don't discuss it, like my comment for parents is, I would encourage you to, whether you actually talk about it or whether you have, really good quality books around that kids can access on their own, because they're going to get an education. It's just, you'd rather it wasn't from like the kid on the playground. You'd rather it was good information.
Absolutely. Right. They're getting so much information, especially today, so much information from so many places. And just like in medicine, when we talk about reputable sources and journals, it's the same, but with our children and the input they have, we can't be everywhere to make sure those are reputable. So if they're going to hear it, you want your voice to be the loudest.
Sure. And you want to always be the person they can talk to about it. And I'm not saying that's fun. It's challenging. There's, again, good books on my website about this that help guide parents in how to have those conversations. But I would say if we can be there for our kids around this, then we're doing a great job.
Yes. Well, when so much of sex and intimacy is dependent on communication between partners, how do you help effectively when you may only be seeing one person of a relationship?
Yeah, I think that's a great question. I mean, ideally we have, the whole couple in the room. Ideally we have, in regular therapy, the whole family in the room, so that we can really work with the system. But I think we can do a lot. Some partners are not interested in going. I think one of the most problematic ways this shows up, though, is when the couple sends one partner who they feel is broken to be fixed. And that's not generally all that successful. I think both partners often need a re-education. Both partners need to look at the resources and understand how to help when things like pain or low desire show up. Exactly.
Pain, that's a really difficult topic as well, because pain can be, you can have emotional trauma and issues that can manifest physically. You can certainly have pathology in the pelvic floor, as you talked about. It's a difficult topic to navigate. And if somebody has pain, they are not going to want to have sexual intimacy.
Yeah.
especially penetrative intimacy.
Yeah, and I would say, I want our listeners to remember that pain isn't it's not normal, like we rarely say that in sex therapy, but if you are having persistent pain, you want to get that checked out with your provider. You and I share patients and talk about all the different sources that pain could be. Sometimes it's a muscle issue, sometimes they need a pelvic floor physical therapist, sometimes it's tissue or nerves, post-childbirth issues. And sometimes it's a conditioned response to having pain for so long that the brain, tells us we have the experience of pain even when the source has been removed. So, we work on that in sex therapy too.
Something that I just really dislike is when people are told, if they express an issue with sex or with their desire and they're told to just go and have a glass of wine.
Yeah.
How do we change that narrative?
Yeah, well, and that narrative started with Masters and Johnson and their lovely, incredible, the founders of sex therapy. And at the time, that seemed like the advice to be giving. You and I can realize why that's problematic and often, not going to solve the issue in a sustainable way. Again, we want people to be having the kind of intimacy and sex that they want to have again, that they feel drawn towards. We want the focus to be pleasure. And we have to often get some things out of the way in order to get there.
I also see that sometimes if a partner or a person brings up difficulties with sex, that the first thought is to send them to therapy. Not necessarily sex therapy, but just in general to therapy. What are your thoughts about that?
Yeah, I mean, while I want everyone to have access to, a supportive provider, mental health provider, I think that back to our sex therapy model, I mean, so many people need to start further back in that. You don't have to go straight to intensive therapy. A lot of people don't need that. Sometimes you just need education, resources, and to look at your garden and figure out what is not working for me here or what in our gardens isn't matching up, to use that metaphor. I think there's a lot people can do on their own, improving their relationship with their body, improving communication between partners. There's a lot that can be done outside of the therapy room. And sometimes people do need therapy. A lot of mental health concerns that people have, let's say bipolar or anxiety or trauma or depression, they have a sexual impact as well. So, you want to make sure you're getting optimal treatment for any mental health things that are coming up as well.
I like that, having a collaborative approach as well, because there are physical issues that people may be having, in terms of pain.
Yeah.
And I think that sometimes they're not visible. And so it's easy to send patients to someone else, here, go to them. But there are pain issues that may not have visible signs.
Sure.
But can have treatments. And so those things need to be evaluated thoroughly.
Right.
And maybe working together with sex therapy or pelvic floor physical therapy.
Right. Looking at hormones, looking at medications that get in the way. I mean, all kinds of things.
I love my hormones.
Yes.
Right. Yes, and the medications, that decrease desire, and medications like that increase pain.
Absolutely.
So another narrative. I've had female patients that have stated that their sexual experience ends with climax of their partner, not their own climax. Right. And other females that have said they're unsure whether or not they've ever climaxed in the past.
Right.
And these may be middle-aged women or older that are unsure. So can you address the gap in satisfaction and between men and women specifically? And do you think that each sexual experience needs to end in climax of both partners?
Yeah, so let's unpack that question. I would say this is more of an issue in the research for heterosexual couples than for other sorts of relationships. Dr. Lori Mintz wrote a book called Becoming Clitorate. She has some incredible TED Talks and resources online that talk about closing the orgasm gap. as she would say. And, there's a couple of real big issues with this. One is that, the average time, let's say in her research, that it would take a male to reach climax would be 2 to 10 minutes. The average time for women is 15 to 45 minutes. I think time is the most important factor in this, and setting aside and being patient and giving space for that time. I think that's our best shot at that. Also, it is only, in her latest research, only 4% of women climax from penetrative sex. This is why we're trying to take it off the pedestal. It's not the best way to access a shared experience for both. It's an important part of a lot of people's, what we would say, sexual script, and that's great. But I would say it deserves a lot less focus than it gets if we're really looking at pleasure and not performance.
Oh, I'm glad you shared that about the orgasming is only 4% from penetrative.
Right.
I knew it was very low. It's the clitoris that we need to stimulate in women. Mm-hmm. And so it depends on your anatomy and how close the clitoris is to the vagina, really. Mm-hmm. So either from vibration or stretch could lead to it. But yes, I think people may feel abnormal if they're not having a climax from penetration.
Right. And the research would suggest that is much more normal.
The norm.
Than one would think.
So do you think each experience needs to end in a climax?
Yeah, I'm glad you asked that because while we want to really focus on closing that gap in general, in the research, when we ask, let's say heterosexual men and women, their definitions of a satisfying sexual experience, which is how we would talk about it in the research, an SSE, not super erotic, but it would be, men do often include climax as a pretty necessary part of their sexual response cycle. And we would say that women would like that prioritized from time to time, but don't tend to say, or a lot of the time, but don't tend to say it's a necessary piece. And so sometimes we get into this tyranny of climax. Some very well-meaning authors and researchers have put so much emphasis on, on climax that it turns into performance anxiety. It turns into this thing that defines, what successful sex is. And you lose track of pleasure, I think, when you start to put this outcome on it.
So how do we close this satisfaction gap?
Yeah, I think, like I said, taking enough time, knowing that different bodies need different stimulation to get there. There's also, in Becoming Clitorate, there's a really good chapter on different scripts you can actually follow of like, hey, start with this. For a lot of people, by the time the heterosexual male has climaxed, that's sort of the end of the encounter for a lot of couples. And so, you'd want to look at Ian Kerner's work, too. He wrote the book, She Comes First. It's an excellent resource for men in understanding how to change that script up in a way that brings a lot more pleasure and ideally a lot more frequency. Again, we want to be having the kind of sex we want to have again.
That's right. And that sex may be different than what it was earlier on in the relationship.
Right.
Both of your desire changes and the type and the frequency changes. Mm-hmm. Another thing, I like that She Comes First. I haven't read that, but I know that when I'm talking about pain in women, typically having a climax prior to penetration eases that and makes a woman more prepared for intercourse.
Sure.
So that's something that's noticed.
I mean, my main advice to women would be, not even needing a partner for this part necessarily, but like giving their bodies a chance to access any of this in a relaxed way. And maybe that means taking a bath to have the benefit of heat and, and blood flow to the area so that you're feeling more sensation. There's all kinds of ways that I think women can be kind to themselves and empowered to, bring themselves to the table in a way that's comfortable and fun.
Right. Does sexual dysfunction exist in same-sex couples?
Yeah, absolutely. Everybody, dysfunction is everywhere, Dr.
We all
Woodruff.
share.
Yes, and all kinds of relationship formats and all kinds of bodies. I mean, we can get, yes, we can all have our challenges. We can all have breaks that get put on, pain, all kinds of things. Although the latest research would suggest that, for example, in lesbian relationships, maybe frequency in some couples is not as high, but satisfaction is often rated as higher. There's less of a gap, certainly, in terms of climax. So there's actually some, benefits in some other kinds of relationship.
I would think in a same-sex couple, you know your anatomy better. And so you know your erogenous areas.
Sure.
Or are those erogenous areas different for different people?
Oh, yeah. Different for everyone. Nerve endings. Again, like that, do not assume your partner is anything like you, really applies to everyone. You may have the basics figured out if you have a same-sex partner. But my goodness, bodies are diverse in what they've been through, what their nerve endings are like, what kind of touch they like. And so, great to communicate about that. In sex therapy, we often use pleasure mapping. So we'll have people, and really important after experiences like cancer or chronic pain, things like that, to show that, there are parts of your body you may be used to like to be touched that are off limits now, or there are times maybe you would like a less generally focused approach. And so communication and a visual map often really helpful.
Yes. Mm-hmm. And speaking of cancer, after cancer treatments, your body changes.
Yeah.
Your emotional health changes, your mental health changes.
Yeah.
How do you approach a couple who they do want to have a sexual relationship with each other, but they have physical and emotional issues that are preventing them?
Yeah, I think that's unfortunately becoming quite a common issue, in all kinds of partners, whether you've had radiation, whether you've had chemo, whether you've had surgical removal of cancer, that may lead to changes in, erectile functioning. It may relate to changes like with prostate cancer. And I think, sometimes women are put on anti-estrogen, of course, in order to keep estrogen-sensitive cancers at bay. And that has a real impact on the body. So we need good medical care. We need often lubrication. We need there are even vibrators that are specifically designed to help women post-cancer so that they can help regenerate, tissue health and nerve health. And I think really this is a great area to take the focus off of penetrative sex. It really is an opportunity to diversify the ways in which you look for pleasure and access it, and can actually be pretty, more satisfying for couples than it was before. I don't want to sugarcoat it. I think, there can be some very real challenges and pain. But with good treatment, I think people can expect, and a little creativity, to, be able to connect.
And the same with other chronic medical conditions. Is there a role for sex therapy in someone that has survived cancer or is undergoing treatment for a chronic medical condition that is limiting their
Sure. I mean, I work with clients, maybe, men who've been put on beta blockers or who've had heart issues, multiple sclerosis, lupus, Ehlers-Danlos syndrome. We see a lot of that in sex therapy, and work to help people figure out ways to access pleasure, even when the body is providing some barriers to that. It's, I guess my, soapbox about that would be every person deserves pleasure. And, while we don't see a lot of disability or variance, even diversity in who is a sexual person, right, in this culture, yes, I think that's we're doing better at that. And that's good to see. Diversity in sexual health.
Yes. I mean, that's so important to bring up with even disabilities, that perhaps somebody with a physical disability is seen as less sexual,
right?
Not desiring of sex. Mm-hmm. And perhaps they have issues. Are there things that in sex therapy you can help with people who have physical disabilities who may need help with even discussing how or positioning or
Sure. Yeah. You know, and a really fascinating place that this gets talked about is like spinal cord injury. It's really fascinating. People would assume, I think, or people do assume like, oh, well, that's it for sex. And my goodness, it's amazing to see how people access a resilient sex life through, you know, really different means. And so, again, complicated topic, but one that we're all trained to work with and make room for and, you know, and celebrate the dignity and the pleasure of all people and all bodies.
A question that came in for you is, what is the age range of people that you see in your office?
Yeah. So I see from teens to, you know, I've seen people in their mid 80s and maybe even older than that. So sexuality throughout the lifespan. That's part of our education and training to be able to help, you know, all throughout.
I like that. It's open for everyone. It's a pleasure experience. And in your office, you are there as well as other certified sex therapists to educate as well. Well, we are about out of time today, but I do have time for you to share some of your final thoughts with us.
Yeah, I guess I just hope our listeners will get curious about themselves. Anytime we can bring curiosity versus judgment to ourselves, to others, to our partners, I think that's a great place to start. And I would encourage you to look into Emily Nagoski's work, think about the garden metaphor, think about what's in your garden, what do you want to nourish and grow, and what weeds need to be pulled. I hope that people have learned something and will follow up with some resources. And thank you again for honoring this topic. It's really cool to be here today.
I actually have another question about where's the first step that people go if they feel like they're being held back sexually, or they want to find out if they are normal. And I think today you shared that everyone is normal. Yeah. And we're all so different. What's the first step that they take?
Well, I think one of the first places is your provider's office. Actually, I think a lot of people, when they go for their annual exam or when they are going to see their general practitioner, it's good to ask that their body is healthy, and then, you know, seeking out sex therapy and seeking out resources that educate. And seeing how they fit for you.
You've given us a lot of great information today and a lot of resources where we can go and learn more. Thank you for tackling this sensitive subject to us. Thank you to our expert, Ms. Rebecca Love, for being with us today. Thanks to our audio engineer, Chris Hyde, and our producer, Madeline Rose. You can find more information on this in previous programs on our website at alaskapublic.org. Let us know your thoughts or suggestions by emailing us at line1@alaskapublic.org. This has been Line 1, Your Health Connection. I'm your host, Dr. Jillian Woodruff. Thank you.